If you've had endometriosis surgery and you were told that everything looks great, by now 6, 9, 12, 18 months have gone by and you're still not pregnant, this episode is for you. Hi, I'm Dr. Jane Levesque, and this is the Natural Fertility with Dr. Jane podcast, where we help couples uncover the real reasons behind their fertility struggles. So today I'm going to walk you through a real client story to show you why surgery by itself is often not enough for endometriosis, what got missed on her functional labs, and how looking through a fertility lens completely changed her plans. So here's the big idea. Endo surgery can be a powerful tool, but if you don't change the environment, the endometriosis to show up in the first place, recurrence is very likely, which is what happened for this patient. 18 months post-surgery, she is having recurrence already. Maybe this sounds like you, and maybe you were told you need endometriosis surgery, or maybe you had surgery already and your surgeon said that it went well and it should help your fertility. 6 months, 9 months, 12 months, 18 months have gone by and nothing has happened, and you actually are starting to experience symptoms again. Your bloating is coming back, your cycles are painful again, or maybe they're heavy, maybe you're getting a little bit more tired or moody, your digestion is feeling really sluggish, and you might be doing all the right things like eating healthy and taking supplements and seeing a naturopath and a functional medicine provider. You just feel stuck. And hearing that recurrence is happening after you already went through this big surgery is probably one of the most heartbreaking things that can happen, because not only were you expecting the surgery to help you conceive, now the idea of having to have multiple surgeries all the time seems ludicrous. So most women in this situation are kind of told that surgery is the only thing you need. There's nothing else you can do about it. You probably need to do IVF, or you need to do surgery every couple of years. And then on the holistic side, you might be getting the protocols for your gut or your hormones or detox, but it just feels all fragmented. Like nobody is putting all of the pieces together. No one is stepping back and saying, okay, does this actually explain why she has endometriosis in the first place? Is she actually ready for surgery? And is this something that's going to work for her? Or are we missing something else? What's going on for her partner? Have we addressed his component to make sure that it doesn't impact her diagnosis and whatever it is that we're seeing in the functional labs? So you kind of end up with a bunch of band-aids and then a lot of this fragmented information from different practitioners. And obviously that feels overwhelming. And a lot of the times it feels like you're just grasping at straws. So here is kind of the new lens that I want you to look at. And I'm actually going to share labs, and these are functional labs. So I'm not even going to share the conventional labs because they were so fragmented and they weren't even timed properly with her cycle. There was only like 2 out of 8 that were timed properly with their cycle. I'm going to share the functional labs and show you where things got missed and what we could have optimized before surgery so then it wouldn't recur again. And unfortunately, why we have to do those things now, and then see if she does still potentially need another surgery, but prepare her going into it with a very, very different outcome. Endometriosis is not just endometrial tissue growing outside of the uterus issue. We have to understand why the signals are happening. There is a lot going on with the immune system. There's a lot of inflammation. And when I look at the immune system, I'm always thinking, what is the microbial imbalance? What is the toxic load? What is the nutrient deficiency that's causing that immune system to be out of whack? So the surgery might still need to be there to remove the actual tissue, but we have to remove the signal that causes the endometriosis to grow. So if you had surgery, but you didn't feel significantly better and fairly quickly after, and if you did not conceive within 3 to 6 months post-surgery, that is a big red flag for me, and there's probably more things that are going on that we need to address. So let me show you this example. She is 30 years old. They were 27. She was 27 when she first started trying. She had endo surgery almost 2 years ago, more closely to like 18 months ago. And then when she just went to go get rechecked, they actually noticed that there is a lot of recurrence and that she possibly needs to do another surgery soon. So like 2 surgery within 2 years for a 30-year-old is a little bit obnoxious. Now she has a lot of bloating and she feels like she can't lose weight. Her metabolism is really slow. We also looked at her Endo readings, and it doesn't look like her ovulation is very strong. Like that LH peak is quite low for somebody her age. And then, of course, she is just using the Endo to track the way that the app tells her versus how I would tell her. So I want you to track, let's just say day 7 to 8 of the cycle, and usually up until day 21. And even if your ovulation got confirmed on day 15 or 14, I want to see that progesterone rise in the second half of the cycle and make sure that it is higher than the estrogen. And for her, she would always stop on like day 16 and 17 because the app would tell her to do so. And you could see that the progesterone wouldn't be rising very much, and that estrogen would actually be much, much higher in the second half of the cycle than the progesterone, which is already starting to show me that there is estrogen dominance, progesterone probably resistance and lack of progesterone, which then causes the histamine and inflammation and more endometrial tissue growth. So when that's not addressed, then we can't really address. There's no point of doing the surgery because essentially you're cutting out the tissue, but that estrogen dominant environment is still very much there and the inflammation is still there. That sometimes the surgery will actually make things worse, because now you have adhesions that are going to form post-surgery. Now, surgery is a stressful event and the body has to recover from that. So we want to be, really mindful. So let me share my screen and we're going to actually go into the functional lab testing, because she wanted to address and understand the things that were going on. And her functional doctor did not specialize in fertility. And so there's a lot of things that got missed. This is a doctor who actually put her little notes. So that was helpful for me because I could see where the functional doctor actually missed a fertility lens and where she hyper-focused on the wrong things for this specific patient because she has endometriosis. So I actually have not been using GI map for a long time for numerous different reasons. I do not think it's as accurate as I would like it to be. So I'm using a different test, and I'm always making sure and testing things on myself so then we're not wasting time, energy, and money. But for this patient, the H. pylori comes up, and if you can see it, it's below the range, but it's there. And some practitioners will be really picky and say that that H. pylori needs to be completely out of there. If I see it below the range and all the virulence factors are negative, I actually do not focus on H. pylori at all, especially if she doesn't have any symptoms like heartburn and indigestion. And, she has bloating, but her bloating is very low and it's more associated with endometriosis, not with H. pylori. H. pylori bloating is very different. And this practitioner hyper-focused on treating this H. pylori, which obviously the patient didn't feel that much of a difference. She felt a little bit less inflammation, but she didn't notice that big of a difference because that's not the real reason why she's struggling with bloating. The other thing that this practitioner kind of missed is she put, when this is high, we're concerned, but this was low for the patient. And then when I look at some of the phyla, so how much different species in the gut, when I see this elevated, both of them elevated, my first thought was this is really sluggish digestion and things are not moving through properly. So you're fermenting a lot. And that was my first question to this patient when we first met. And she said, yeah, I do feel like my digestion is sluggish. And this was not addressed by the functional practitioner that she worked with. Then we look at the opportunistic bacteria overgrowth, and there's a little bit of overgrowth. It's not huge, but again, this is probably contributing to the fact that she's just not moving things through. It's sluggish. And this is likely because of the endometriosis, and it was all in her bowels, that it's just going to make things move really slow. And that actually tells me where we need to focus on the diet in terms of potentially the killing. And so this practitioner really focused on this H. pylori and that she probably didn't have enough stomach acid. And so she told her to do a lot of those components. I don't want to say it's not right or wrong. It just depends on the fertility lens. I'm looking at it through endometriosis lens. And that H. pylori now is not a concern to me, but the fact that digestion and the bowels are not moving is a concern. There is a couple commensal and inflammatory autoimmune related factors. They were all within range, but they're all in the upper range. And so again, I am looking at the immune system and is this being flared because is upper range. So it's hanging out. There was nothing that was detected in terms of the protozoa and the worms. And again, remember, that's not necessarily going to be the case just because you didn't catch it in the stool analysis. I often look at other markers as well. But here are where some big issues are. The elastase, that's her digestive enzymes. Those are quite low, so improving the digestive enzymes. And the practitioner here made notes on that we want to make sure we improve it. And this beta-glucuronidase is quite high. So I wanted below 2,000. And she made a little bit of a note on it, but she didn't really outline the fact that this is really important for someone with endometriosis. And we'll look at the Dutch test. And again, the problem is it was done by the GI map and the Dutch test. It's either done by two different practitioners or it's done at different times where you're not catching enough of the clues. So the beta-glucuronidase being elevated like this, A, tells me that the gut microbiome is unhealthy, but B, it tells me that she's recycling that estrogen, and estrogen is going to cause a lot of issues for a woman with endometriosis. The secretory IgA is quite low, and this is her immune system, so I know her immune system is suppressed. And when I see this now, the rest of the markers on the stool analysis, I'm thinking it's probably not an accurate representation of how much is going on in the gut because her immune system is so suppressed. We want to see it in the thousands, 1,000 to 1,500 at 614. I've definitely seen it way more suppressed. But for a 29-year-old, that's not good. A 50-year-old at 614, I'm like, okay, that makes sense. But for a 29-year-old, it doesn't. She was 29 when she took that test. The anti-gliadin IgA, this is a response to, immune system response to gluten. So gluten is definitely something that's causing an issue. And then the zonulin is at 87.6. Now, they're saying above 175. I want it below 50. I want it, as low as possible. So to me, this is a leaky gut. And again, the practitioner did not say that the leaky gut is an issue for her, is that if this keeps creeping up, it will be an issue. And I just think that we didn't look at it from optimal ranges. We just looked at it at reference ranges. And for someone who has endometriosis, you're going to be so much more sensitive to your environment that this little bit of leaky gut, this little bit of beta-glucuronidase that's elevated, this little bit of immune system, all of these little bits that start to add up. So I think the reason that it didn't, whatever the protocol this practitioner did with her, it didn't really work, because it was so hyper-focused on this H. pylori in the upper GI tract, where really the issue is much deeper in terms of the metabolism of estrogen and the leaky gut and immune system function overall. So I think the gut stool analysis just barely kind of touches the understanding of what's going on. This patient does have some candida symptoms on her skin. They're not showing up here. So we are testing the vaginal microbiome. We're also looking at like a UTI screen to see if there's candida or other infections. And we are rerunning a stool analysis because there's definitely some things that got missed. Now, if we look at her Dutch, there's a couple of things that are really, really important to notice here as well from that functional naturopathic lens, but also optimal for fertility and what we would see in endometriosis. A couple things right off the bat is she's pushing testosterone a little bit higher. Progesterone looks like it's in good range in terms of her metabolites. Her estrogen is definitely high. When I look at total DHEA production, that's high. Now I am thinking about potential PCOS or PMOS diagnosis here as well. In this patient, when I asked her, she said, I thought I had it, but no one has ever said anything. Now, there's a difference between I have it and it's a full diagnosis to it is starting to develop. And so a lot of the times I'll catch starting to develop, and I do not wait for it to become a full diagnosis because obviously it's a lot harder to treat it, but most people will already have symptoms at this stage. The total DHEA is quite high, and then we see the cortisol is on the low side, especially in the afternoons. And the big thing that I look for is how much cortisol she's producing versus metabolizing. And if these arrows don't match, so they should point in the same direction, how much you produce is how much you should be metabolizing. If that's not the case, then I'm thinking about her metabolism. Is it her thyroid? Is it her liver? Is it her blood sugar? Is it high levels of inflammation? And it's usually all of those above. And you could look at it and say it's not that big of a difference. But again, for a 29-year-old, this is a big deal. She shouldn't have any issues with the metabolism and producing these really high levels of androgens. Now, when we look at the androgens, we can see that she is pushing into the androgenic pathways a lot more and towards 5-beta pathway preference, the enzyme, instead of 5-alpha, which is good because it's not as androgenic, it's not as robust, but she still has high androgens. So now I am thinking about that PCOS, PMOS picture. I am thinking about insulin, liver inflammation, all of that stuff, and her DHEA is quite high. Now remember that this is urine, so it's metabolism. We always want to match it with blood, which is why I never just look at this. And she never had a blood work done around the same time. It was just done at different times. So just because you're running functional lab tests, you can't forget about the conventional and the diagnostics and how they pair up. And this is where I think most functional practitioners who do not specialize in fertility, they just don't think like that. They don't think in the cycles. They don't look at the precision of the ovulation and all the blood and antral follicle count and the surgery, because it's just not their world. Okay, it takes a lot of energy to specialize in fertility, and meaning like there's so much research and stuff that you have to stay on top of that I think these things are just getting missed. So I wanted to give you a perspective if you're like, but I've done all these tests and it's all normal. She was told that she has a little bit of estrogen issue, PCOS developing, PMOS, and your estrogen is through the roof. You are metabolizing it poorly. You're pushing into the red pathway at 9.6%. We wanted below 11. I want her at 7%. She's too young to be pushing into that pathway. So then we're thinking about things like breast cancer and, any kind of cancers really that are driven by estrogen. This is what we want to be able to prevent. And we absolutely can by pushing things towards the green pathway and activating enzymes this way instead of the ones going into the red pathways. And you can see that her methylation is really, really strained. So we are testing her methylation to see what the actual issues are. And if I pair this now with the stool analysis that has the high beta glucuronidase, I can see that her body is not doing well getting rid of and regulating that estrogen. And then when I look at her in Endo, I see that in that second half of the cycle, her estrogen is dominant again because there's just too much of it recirculating. We see lots of these kind of red flags, if you will. The vitamin B6, when I look at that xanthuronate marker at the high end of range, and even the kynurenate, that tells me there is high levels of inflammation in the body. And the norepinephrine metabolite is quite low. So it tells me that she's probably running on adrenaline. So she's really anxious. She's really overwhelmed for all the, I don't want to say for all the right reasons. Being this young and going through infertility is nothing that I would wish on anybody. But essentially, she felt like she was doing everything right. And she feels like what she has to do is just continue to cut things out more and more out of her diet, being more strict. Yet she's not seeing the results that she wants to. So this is my approach. First of all, we took a really good history, and it turns out during her time where she was getting her period, so her first menstrual cycle through puberty, she was very stressed. There was parents' divorce, and there was a lot of turmoil in the household. This is the time where the ovaries and the brain make the connection. I genuinely think she didn't make a fully formed connection because of the high level of stress that she was exposed to during that time. And so then now, leading from that time where she didn't make a really strong connection, she's still chasing her cycle and trying to figure out what's what. She also doesn't feel safe in her body. She doesn't feel like she really understands her body, and she's frustrated with it because it's not responding to the things that she's doing. So our approach is, number one, to unpack all of that. And then number two, she doesn't need another Dutch, but she does need a stool analysis. She needs a vaginal microbiome. We are going to run a seminal microbiome on him to make sure that there is no stool analysis on him and environmental toxic load on him as well, just to make sure that there's no crossover. I do want to look at mold and candida and rule that out. A complicated UTI screen to make sure there's nothing sitting in the bladder. And then obviously the blood work as well. And then we can unpack and see what's actually causing issues for her. From there, provide the treatment plan, step by step. We look at the data, we look at the Endo, et cetera, et cetera. And then 3, 4, 6 months later, assess and see if she still needs surgery. Because if she does, we'll prep her for that. And the preparation is really getting all the infections in order. But, I'll do like a special 5-day prep right before surgery. And then usually a month after surgery, I have a very specific protocol that I do to prevent adhesion formation and the endometriosis from coming back. That's really important. And then we see if she give her that 3 to 6 months to recover post-surgery, and she should be conceiving. But again, I'm looking at the data. So she might still need another surgery and she might not. But where we have to start, and where I wish every woman would start, is actually doing this proper functional lab workup. And when you have something like endometriosis, you need to work with someone who specializes in this disease, and whether that's a fertility specialist like myself and my practitioners, or like just another practitioner that specializes in that, a general functional practitioner is not going to be able to have the same lens as someone who lives and breathes this stuff, because there's a lot that's changing in this space. So like I said, endometriosis surgery can be a really important tool, but by itself, it rarely fixes the whole problem. And then if you don't feel clearly better after surgery, you haven't conceived within the 3 to 6 months mark, I would not wait until 18 months, because to me, I think it's too late, and likely you've already had recurrence. Then it's a sign that we need to look deeper, not just repeat the same plan. If you've had the surgery, you're doing all the right things, and you're still being told that IVF is your only option, or you just need another surgery, and I promise you it's not because you're broken, it's because no one has really put all the pieces together for you. And this is exactly what my team and I do in the Maximize Fertility program. So if you want us to go through your history and your labs, just like I did with this patient today, and so we can map out a plan for you, go ahead and fill out the application down below. If it's a fit, we'll reach out and we'll show you what it looks like working with us. Otherwise, I hope you found this helpful. Thank you so much for tuning in, and I'll see you next week.